Good afternoon, everyone, and welcome to UT Southwestern Medical Center's Total Care for PD community event brought to you by the O'Donnell Brain Institute. We're excited to continue with our November installment of the Total Care Program's Ask Your Doctor webinar series. We're delighted that you could join us today. Your participation in this event is highly encouraged. Join the conversation in one of these ways: using the chat icon located at the bottom of your screen. If you have a question, comment, thought, um, anytime, pop that in the chat section whenever it's handy for you. It'll be saved for the moderator to share with the speaker during the Q&A portion of the program. If you do prefer to speak, click the raise hand icon. When prompted by the moderator, click unmute to share your questions live. Speaking of live, this is an important note for everyone here. This event is being recorded. By participating in today's session, you consent to be included in this recording. If you prefer not to be recorded, please use the chat feature only. Now, with that housekeeping done and dusted, I'm pleased to hand the floor over to Dr. Sue to begin today's presentation.
Hello, everyone. I am Anubha Sood, and I lead the Total Care program here at the O'Donnell Brain Institute at UT Southwestern. The Total Care program, if you don't know, is a supportive care program that offers all kinds of educational resources, personalized care, and a community for all those who are working through their Parkinson's journey. In December, we will have a holiday gathering in person right here on campus in the Thompson Cancer Center. So those of you who may have attended last time would know that, we have a wonderful meal and, a lot of fun this time. We're going to have someone from Dance for PD, who's going to come over, and we're going to dance and eat and, enjoy the holidays together. So I hope you can join us as well. Um, so I do want to mention our generous donors, the Heggie family, and others who make all of this educational programming possible. If you have any feedback, comments, suggestions, please do write to us at OBI Total Care Program at utsouthwestern.edu. And, you probably would have that email address from all of our various emails that we keep sending to you. So please connect with us. With that, I am very excited to introduce Julia Renaisen. To all of you, I'm sure a lot of you already know her and love her, but for those of you who don't know, Julia has been in the Movement Disorders Clinic here for several years. She is a board-certified nurse practitioner, and she got her doctorate in nursing practice from the University of South Alabama. She also has an undergraduate degree in social work from Texas A&M. With that, I'm very excited to have Julia here talk about misconceptions around Parkinson's disease. Thank you.
Okay, so let me share my screen, see if I can get this going. Of course, it doesn't want to access my PowerPoint now. Let me try it this way. Can you guys see that now?
Yes.
We see it.
Okay, perfect. All right. Okay. So hello, everybody. I'm very excited to be here today. So I've changed the title of this talk just a little bit to not just misconceptions about Parkinson's disease, but myths and misconceptions about Parkinson's disease, setting the record straight. What made me want to give this talk is that I see 16-ish Parkinson's patients a day in the clinic. And I find that I repeatedly get the same questions, comments, concerns about Parkinson's repeated throughout the day by different patients. Myths that are around about Parkinson's, but also some misconceptions about the disease and the treatment and things like that. And I hear these same things over and over and over throughout the day. And so I thought to myself, gosh, there has to be some information somewhere online about this stuff that is misinformation and that is not quite correct. And so I think I'd like to take this opportunity to talk about the top 10 things that my patients bring to me in the clinic that just aren't true. And so I wanted to kind of set the record straight if I could. And so for the patients who know me, they probably know me under a different name. So I was Julia Wick. Now I'm Julia Renaison. I got married this summer. And so that's the name change, but you can truly call me, hey, you, and I'll respond to it happily. So, okay, let's get started. And I do want to apologize. Some of this information that we're going to talk about today may have already been discussed in previous presentations. So I'm sorry if some of this information you're like, gosh, I've already heard that, move on. But just for the folks who haven't heard it, we're just going to talk about it again today. So this is just kind of a little agenda. I'm going to introduce myself briefly, and then going to go over everything, and then we'll have some Q&A at the end. So about me, like, Dr. Sood said, I'm a nurse practitioner with the UT Southwestern Movement Disorders Group. I have my doctorate of nursing practice. So just like the physicians with our group have a doctorate of medicine, I have a doctorate of nursing. So it's a terminal degree in the field. And then I have you'll look behind my name and it'll say APR, an advanced practice registered nurse, AKA a nurse practitioner. I have worked in neurology since 2011. When I graduated from nursing school, and I've been a nurse practitioner since 2017, that whole time practicing in neurology. I previously did epilepsy, memory disorders. Also, I worked in the inpatient general neurology floor in the hospital for hospitalized patients at Dartmouth-Hitchcock Medical Center in New Hampshire. And then I came down here, and I've been with UT Southwestern Movement Disorders since October 2020, so 5 years here with the clinic. Okay, so let's get to the misconceptions. So the number one that I hear a lot is, I have been diagnosed with Parkinsonism. Therefore, I have Parkinson's disease. This is a big one, and it's a really confusing topic, and I think it's a really important one to go over. So some of you may not have heard this. Some of you may have, that someone once upon a time said, you've got Parkinsonism. And therefore, I think most people would think, well, then I've got Parkinson's, but they're not the same thing. So what is Parkinsonism? It's a catch-all medical term for a cluster of physical symptoms. Parkinsonism is not a disease. This is simply a descriptive medical term that we use in the medical field. There is always an underlying disease or condition causing the Parkinsonism, the physical symptoms. And I'll draw this out for people in the clinic. A lot of you probably have already seen my artwork here with the umbrella that I've drawn out. So Parkinsonism is an umbrella term that we use in medicine. So when someone comes into the movement disorders clinic with things like tremor, slowness, stiffness, shuffling of gait, reduced facial expression, reduced arm swing, and a quiet voice, amongst other things. When someone comes in with kind of all of these things, we'll stamp that person with the diagnosis of Parkinsonism. That's a catch-all term for all of these things. Now, a person may not have all of these things. They may have a couple of these things. They may have several of these things, but we say that person's got Parkinsonism. They've got physical signs that make them look like they have Parkinson's. But there's always a disease underneath here causing this stuff, these symptoms. Number one, the most common and the most famous cause is Parkinson's disease. This disease will cause these things, which we call Parkinsonism. But it's not the only disease that will cause a person to have these things. Lewy body dementia will also cause these symptoms. That's what the actor Robin Williams had. Progressive supranuclear palsy, PSP. This is another condition that will make a person have these symptoms. Multiple systems atrophy, also known as MSA, will make a person have those, as well as a stroke. If a stroke hits in just the right place in the brain, it can trigger these symptoms. And exposure to certain psychiatric medications will cause a person to have some of these symptoms sometimes. These would be antipsychotic medications. You take some of those meds for a while, and then all of a sudden you'll start exhibiting some of these symptoms. Not always, but sometimes you can. So you can have a medication-induced Parkinsonism. So how do you know which of these conditions is causing these symptoms? Well, it's up to your medical provider to determine which of these diseases or conditions is causing a person to have these symptoms. And so we do that by taking your clinical history. How long has this been going on? What started first? How big are these problems? What have you tried medication-wise? What treatments have you had to improve these things? You oftentimes, by following along with someone for a few years, it will become clearer and clearer which of these is likely to be going on causing this. However, the treatment is almost always the same. No matter which of these is causing this, the treatment is almost always carbidopa-levodopa, aka Sinemet, aka ropa-dopa, lovadopa. People just kind of mangle it. It's a hard term to say, but it's almost always that medication in some form or fashion is used to treat any of these, which are all causing this. So just because a person has Parkinsonism doesn't necessarily mean they have Parkinson's disease, because as we see, there are several other things that can cause a person to have this. But again, the treatment almost always will be carbidopa-levodopa, regardless what's going on here to cause this. So misconception number 2 that I hear: I don't have a tremor, therefore I cannot have Parkinson's. That's a myth. You absolutely can have Parkinson's without having a tremor. A lot of my patients have no tremor, never had a tremor, but they've got Parkinson's the exact same as somebody else who does have a tremor. So to get the diagnosis of Parkinson's, you must have the following. And this is kind of a busy slide, but it is the medical rules, guidance that clinicians have to follow when diagnosing Parkinson's. So to get the diagnosis of Parkinson's, you must have the following. For the diagnosis of clinically established, like pretty definite Parkinson's disease, you've got to have Parkinsonism, absence of exclusion criteria, which we're going to go over here, and then at least 2 supportive criteria. We're going to go over that too. And then there's also a diagnosis of clinically probable PD. So this is pretty sure you've got Parkinson's, and this is probably Parkinson's, which would be Parkinsonism, absence of exclusion criteria, and a balanced number of supportive criteria and red flags. And I've got more. We're going to go into those here. So let's start with number 1, Parkinsonism. To get the diagnosis of Parkinsonism, we talked on the slide previously about some of the things a person can have, but the most common ones are you've got to have, number 1, bradykinesia. That is a medical term for slowness of movement. You've got to move slowly, not necessarily snail paced, but you have to have slow movements. When you come into the clinic and we do that, physical exam where we have you tap your fingers and open and close your palms, we are looking for bradykinesia. We're looking for if your hands are moving slowly when you perform those everyday tasks. So you've got to have bradykinesia to be diagnosed with Parkinsonism, plus either tremor or rigidity, meaning stiffness of your muscles. If you want to extend your muscles, they're awfully stiff, hard to move your legs because your legs are very stiff. So you've got to have slow movements plus either tremor or rigidity. But as you can see here, it's not and tremor. You don't have to have slowness and tremor. Tremor can be part of it, but you may not have tremor at all. You may just have slow movements and stiff movements. You've also got to have, as we've seen here, at least 2 supportive criteria, which is, benefit response to the medicine. So if we give you carbidopa-levodopa, you get better. That's a supportive criteria that this is Parkinson's disease. Also, if you've got levodopa-induced dyskinesia, that's those Michael J. Fox type wiggles that you see, not tremor, which is a rhythmic back and forth small movement, but a wild kind of snake-like wiggling. That's a levodopa-induced dyskinesia. It is a side effect of the dopaminergic medications. Rest tremor of a limb would be supportive criteria, and the presence of either olfactory loss, meaning you don't have a very good sense of smell, or this cardiac sympathetic denervation on MIBG scintigraphy, which we don't even really do anymore. So can't really talk to that. But a lot of folks who have Parkinson's can't smell, and that's a supportive criteria. So you've got to have these things, but you also cannot have any of these exclusion criteria. And this is a long list. We're not going to go over all of it. But if you've got these things, those are what we call red flags, which would make us think this is not garden variety Parkinson's disease. This is another of those conditions that was on the previous slide, like progressive supranuclear palsy or MSA or things like that. These would be red flags for what are called an atypical Parkinsonism. It can also cause slowness and stiffness and everything, but have other symptoms that come along with it, as seen here.
Julia?
Yeah.
I am so sorry for the interruption, but
okay.
to make sure that we get the best recording possible, there's a little note at the bottom that says that the Zoom app is sharing your screen, and it's asking you to either stop or hide.
Sorry.
No worries.
I thought that was just something I could see. Sorry about that, guys.
No
My
worries
apologies.
at all.
Is that better?
Yep, that worked. Thank you.
Okay, great. Okay. All right. Sorry about that. So number 3, my friend has Parkinson's and is taking Rytary or Crexont or whatever, and he's doing so well. I think I'd do better if I went on that instead of Sinemet, which is just regular carbidopa, levodopa, 25/100, or something else. And I hear variations of this in the clinic, but it's usually my patient is on a certain therapy for their Parkinson's, but they have a friend or somebody else in their support group who's taking a different medication, and that person seems to be doing better than I am. So, hey, that I think I should be on that medicine because that person's doing really well, and I want to be doing as good as that guy. This is a misconception I hear a lot. So let's talk about carbidopa, levodopa. And I'm sure you've heard this a million times already. Sorry if this is, repeat information, but carbidopa, levodopa is the mainstay treatment of all Parkinsonian syndromes. Almost all Parkinson's patients will go on this medication at some point in their lives in some form. Levodopa, so this second part, this is the important part. When we talk about carbidopa, levodopa, the most important part is levodopa here. So oftentimes you'll hear me just refer to it as levodopa. But levodopa is synthetic man-made dopamine, the chemical that Parkinson's patients do not make enough of. This is the whole problem in Parkinson's, is Parkinson's patients cannot make enough dopamine. The dopamine-making cells in the brain are dying off. And so a person does not make enough of their own dopamine, so we have to give them levodopa, synthetic man-made dopamine, to supplement what their brain isn't making enough of. Carbidopa is the chemical that helps the levodopa cross the blood-brain barrier and get into the brain, reducing nausea and allowing for more absorption of the levodopa. If you just took levodopa, not very much of it would be able to actually get up to the brain because you've got this barrier that keeps certain things out, so we don't get terrible brain, viruses and infections all the time. And that's great, but it also makes it difficult to get medications across that blood-brain barrier into the brain to take effect. And that's the problem with levodopa. If you don't have carbidopa kind of taking levodopa's hand and pulling it across the blood-brain barrier, not very much of that levodopa, that man-made dopamine, is going to get up into the brain and take effect. So you got to have carbidopa always with the levodopa so that it'll work efficiently. And it cuts down on the nausea. Levodopa is incredibly nauseating. If you add in carbidopa, it tends to reduce the nausea. So there are many different forms of carbidopa, levodopa. So we've got Sinemet, which is, carbidopa, levodopa 25/100 or 10/100. You've got Sinemet CR or ER, which is quote unquote controlled release. It comes in a few different strengths here as well. You got Rytary, Crexont, which is the newest oral form, Vyalev, which is a pump form of the medication, and Duopa, which is, the tube form. And I think Sarah talked about these last month, about the Vyalev and the Duopa. However, these are all the same medication. They're the exact same medicine. They are all forms of carbidopa, levodopa, Crexont, Rytary, everything are exact same thing, carbidopa, levodopa. However, they're simply packaged / formulated differently. So they are absorbed differently into the body, lasting different amounts of time. So some of these, like Rytary and Crexont, are long-lasting medicine. They're packaged in little capsules with beads that slow release over time, so they last a little bit longer. Sinemet, regular carbidopa, levodopa, is immediate release. When you take it, it's going to all release at once very quickly. There's pros and cons to all the different forms of these levodopa. Some kick in much faster than others. That would be the immediate release carbidopa, levodopa. Some last much longer than others, like Rytary and Crexont. And some are far more expensive than others, especially Crexont. Rytary was really expensive. It's gone generic, but it still is fairly expensive for people now. But that Crexont especially is real expensive for most people. Carbidopa, levodopa is dirt cheap. So when we decide to start somebody on a form of levodopa, we've got to take all these things into consideration. What's the biggest problems here? And what is this person going to be able to afford? And then we'll start you out on something. And then if we run into problems, like your medicine's working well, it's just not lasting long enough, well, then we'll talk about switching you to the Rytary or the Crexont or a longer lasting thing. Or if you've got motor fluctuations or you've got GI problems affecting the absorption of the medicine, we may look at Bioleve or Duopa. However, these are all the same medicine. So just because your friend is taking one variant of the levodopa, no, you just need to know they're taking the same medicine as you are, just packaged differently. But you're always welcome to ask, like, hey, do you think Rytary or Crexont or whatever would be a good fit for me? And I can explain at that time why that would or wouldn't make good sense for you. So moving on. Number 4, I don't want to start or increase levodopa because I don't want to become tolerant to it. I don't want to use up my ability to benefit from levodopa. The more I take, the faster it won't work. This is probably the number one misconception that I hear in the clinic from patients. They seem to have a fear. There must be some information online about this somewhere saying that if you increase levodopa, well, it's not going to work at some point. And that's not true. So, number 1, you cannot develop a tolerance to levodopa. It's not like you're going to take this medicine and one day your body's going to get used to it and it's not going to work anymore. Nope, that's not ever going to happen. You can't. Humans make this medicine. They make this chemical. My brain makes it, your brain makes it, everybody's brain makes this. You can't develop a tolerance to something you make on your own. What happens is Parkinson's is a progressive neurodegenerative condition, meaning that it will naturally worsen over time, no matter what you do, no matter what you take. It's going to worsen over time. Your brain will continue to lose its own dopamine-making cells as the years go by, and you will naturally require more and more levodopa or adjunctive therapies like rasagiline or entacapone or things like that to supplement what your brain is making less and less of. So again, we all make dopamine. The problem in Parkinson's, again, is that those cells that make dopamine start to die off. And every year that goes by, you will have less and less of those dopamine-making cells, requiring you to take more and more levodopa or more frequent levodopa or whatever to supplement what your brain cannot make enough of. So you don't develop a tolerance to levodopa, but your Parkinson's progresses and you have less and less dopamine cells that make less of your own dopamine. So you will require more levodopa because that's the natural progression of Parkinson's. By the time you start to show physical symptoms of Parkinson's, you have lost approximately 80% of your own dopamine-making cells. So by the time, Parkinson's doesn't develop overnight. It cooks for years, sometimes decades, before the symptoms start to show. So by the time you start tremoring or you start having trouble walking, you only have about 20% of your own dopamine-making cells. And then as the years go by, well, you got less and less. So then 20% becomes 19, becomes 18, 17, 16, whatever, et cetera, et cetera, et cetera. And so you're going to require more medicine because to supplement the fact that you only make 10% of your own dopamine or whatever as the years go by. Also, another fact to consider is your therapeutic window will naturally narrow as well over time. meaning you'll have a narrower sweet spot where your medicines work just right without side effects. So, whenever you first start on a medicine, it's pretty easy for us to get you a dose of medicine that works pretty well without causing you side effects. But as the years go by, your response to the levodopa is going to become more volatile. You're going to require either bigger doses, more frequent doses that then put you at a higher risk for side effects like dizziness, hallucinations, or those dyskinesias, those wiggles, because your brain is losing less and less of its own dopamine, or making less and less of its own dopamine. I got to give you bigger and bigger doses of levodopa. The more of any medicine you take raises the risk for side effects. And so the therapeutic window can narrow, can be much easier to overshoot you to where you have dyskinesias or other side effects. And then your medicine, because you're running through it faster because you make less and less of your own dopamine, you're going to end up using it more frequently as well, which can also give you, more side effects. Number 5, I feel best in the morning before I take my meds, then worse as the day goes on. And I tremor far worse for 30 minutes after I take my levodopa. I think my meds are making me worse rather than better. I hear this a fair bit as well from my patients. That they feel like the medicines are making them worse instead of better, that they tremor more after they take their levodopa than they do beforehand. This doesn't happen often, but I do hear this, probably once or twice a week, I hear this from patients. So what's going on here? So dopamine, the most important chemical in Parkinson's, we've been talking about it. Dopamine levels rise and fall throughout the day. This is for all humans. Levodopa, aka dopamine, whatever form you take, should be viewed as fuel that powers your muscles to move correctly, just like gasoline powers your car to go. And I use this, analogy in the clinic all the time about your body is a car, okay? It's a vessel that you're moving. You've got to put gas in that car to make it go. And normally, a brain without Parkinson's will make its own gas, its own dopamine. So it powers your body and your muscles to move. But when you've got Parkinson's, you cannot make enough of your own gasoline. So you have to take supplemental gasoline to fill up your gas tank so you can go and your muscles can move. But just like any car, the faster the more you use your body, the faster your dopamine gas tank will run down. Just like the faster you drive a car or the more you use a car, the faster you're going to run down that gas tank. And that's the same thing that goes on here with the levodopa. Every time you take a dose of levodopa, you're putting gas in your tank, filling your gas tank up. But then as you move around, you walk, you do things, you run down your gas tank, and then you can start to get symptoms. Sleep restores dopamine levels because you're not moving your body or driving your car. You've parked your car for the night, so it's not moving. And you are still making some of your own dopamine, even if you only got 20% of your dopamine making cells. At nighttime, when you're not moving, well, your gas tank is rising because your brain is making its own dopamine overnight. Not much, but some. But if you're not moving that car a lot at night, you're not moving your body, you're not running down the gas tank. So it's not uncommon for your dopamine gas tank to feel pretty full in the morning, and thus you feel good. Because you've not moved your body, you've filled up your gas tank naturally overnight with the little amount of dopamine you still make. And so you feel really good in the morning. And then you get up and you start your day. As you start moving around in the morning, your dopamine gas tank starts running down because you're burning that gas because you're moving, and then your tremor starts occurring. So it's very normal for a lot of people, not everybody, to feel best in the morning after they've had a refreshing night's sleep, their dopamine gas tank's full. Then they start moving around, 30 minutes, an hour later, there's tremoring, they're feeling worse. Levodopa levels rise and fall as your medication metabolizes out, and then you move your body and that'll metabolize it out faster. If you tremor worse after you take levodopa, it's likely because you are in the very bottom of your medication cycle, aka your gas tank is empty. When you take a pill, your gas tank doesn't immediately fill to full. It takes a while for the medicine to absorb, get broken down by your body, taken up across that blood-brain barrier to take effect, and your gas tank to fill to the top. Therefore, when you tremor more after you take your levodopa, it's your gas tank sinking to bone dry while it's waiting for the medicine to absorb and take effect, and thus fill your gas tank to the top. Shortening your dose cycle can usually help this. Moving your doses closer together so your gas tank doesn't run down between doses to bone dry usually will help improve that problem. So, and I included this slide here so you could kind of see what I'm talking about. So when you wake up first thing in the morning, you've not moved, your car's been in the garage, so you've made your own dopamine overnight. So you feel pretty good. You wake up and you're feeling here, your gas tank's full. Then you get up, you start moving, cooking breakfast, moving around, walking the dog, whatever. And then your tremor starts up. You're starting to shake, 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 because you're running down your gas tank as you're moving your body. And then when you get to, about here or so, okay, I need to take levodopa. My tremor's getting bad. Well, you take that levodopa and it doesn't immediately cross the blood-brain barrier and fill up your gas tank. It's got to be broken down by your stomach and then taken up through your intestines, then across the blood-brain barrier, and then the drug level will start to rise and your symptoms will go away. But what happens is that about here, when a person takes their medicine, they're like, oh, my tremor gets worse after I take this medicine. And that's because that medicine is in the process of getting broken down, taken up to the brain. So your tremor is going to be at its worst here because your drug level is lowest because that medicine is trying to make its way up through everything up to the blood-brain barrier into the brain. And then, an hour or so later, okay, then it starts to feel better. But just because you take a pill, it'll take 30 minutes to an hour for most people's gas tank to start filling up again and for them to feel better. And this is the cycle that repeats all through the day, up, down, up, down, up, down. But if we move these doses closer together, you take that medicine sooner than later, that oftentimes can help reduce those sharp up and downs that you feel throughout the day. Number 6, my tremor is occurring when I'm stressed, anxious, nervous, in traffic, etc. I think I need more medicine. My tremor's breaking through. I hear this a lot, at least every day, that my tremor's coming through whenever I'm really stressed. So I need more medicine. I need something to help stop that tremor. Tremoring when stressed is a normal human physiologic response. All humans will tremor a little bit when under intense stress. Even me, and even people who don't have Parkinson's. If we are super, super stressed, we've come through a really stressful time, we'll all tremor a little bit. But Parkinson's patients will tremor far more because of their baseline tremor tendency. This is your fight or flight response kicking in. Adrenaline is pumping, overriding your medicines and causing the tremor to flare. There's no good fix for this. Though sometimes I'll let patients take a little bit extra levodopa or trial propranolol, which is a blood pressure medicine that can potentially blunt high emotions. I usually give this to people who are still working, giving big presentations before a board or things like that, or have to go to a social dinner or things like that, because that can reduce your ability to get really stressed out. But this is not for everyday use, and certainly not for people who've got blood pressure problems or heart rate issues or things like that. Asthma, you can't use it as well. But my point being, if you find yourself driving in traffic, stressful traffic, which is our life in Dallas, it's going to be common for you to tremor more because your fight or flight response is kicking in. Adrenaline is pumping, you're stressed out, it's going to punch through the medicines. And that's a normal human response. Calm, deep breathing, calming yourself will quiet that tremor and stop the adrenaline from pumping. The only way to stop this is to stop the adrenaline from pumping and breaking through your meds. So you got to find a way to calm yourself down. And usually calm, deep breathing will quiet that tremor enough and stop the adrenaline from pumping. It'll go back to its baseline. Number 7, I want deep brain stimulation, aka DBS, so I don't have to take medicines anymore, and so I won't ever tremor. There is no way to take away tremor, slowness, stiffness at all times. Your Parkinson's symptoms will occur at times, no matter what medications or interventions you have. It is not possible for us to take away all of your symptoms all the time and for you to be symptom-free 24 hours a day, 7 days a week, no matter what you have done. It's just not possible. I wish it were. I'm desperate to make that happen, but I just can't. It's not possible. DBS can be a great additional option for some patients who have an unpredictable response to their medications called motor fluctuations or have severe side effects from their medicines, but you'll still have times where symptoms are present. DBS is not a cure, and I think that's a misconception a lot of patients have is if I just get that brain surgery, I don't have to take pills, I won't have side effects, and I won't have symptoms. I'll be great. That is not going to be the case, and you better get that straight before you go have brain surgery, is that you are going to have symptoms, whether you have that brain surgery or not. It can be a miracle for some people, really can help reduce their symptoms, give them a more consistent response and a far better quality of life. For some patients, it's not the right thing for all patients. But even then, you'll still have times when your symptoms come out. And getting DBS does not mean you can stop taking medications. In fact, most DBS patients continue taking levodopa, though perhaps they can take lower doses and hopefully that'll reduce their risk of side effects. But the large majority of patients who get DBS continue on levodopa, some form of levodopa. I think in my time in movement disorders, I've seen maybe only a couple patients whose DBS, was so successful that they were able to come off medicines. And I have seen patients who've done that. And then a couple years later, as their Parkinson's naturally progresses and their symptoms naturally worsen, which is something that's going to happen whether they get DBS or not. DBS doesn't prevent the Parkinson's from progressing or worsening. It's going to do that regardless again. I have seen people have to go back on medicines who previously were able to go off. Again, not very many of those, but they have had to go back on it as well as Parkinson's continues to march on and worsen their symptoms. The goal for us when we see you is for you to feel your symptoms are pretty well controlled most of the time. But I cannot make it perfect. I cannot make it so that your symptoms are always controlled all of the time. That's unrealistic and it's not going to happen. There is no way to take away all symptoms all of the time. But again, my goal is for you to feel pretty good most of the time, which may be disappointing to some, but oftentimes I can get you to feel pretty well controlled most of the time. Number 8, what about stem cell trials, red light therapy, vitamins, diet? I heard there's a functional medicine doctor who says if I buy his program, I can cure my Parkinson's or stop it from progressing. This is, again, probably the most common or second most common thing that patients want to bring up and talk about in clinic. That is just not true. So let's talk about stem cell trials. I get this question probably 5 times a day. I'm not even joking. Stem cell trials have not proven to be effective in Parkinson's disease. In fact, stem cell trials so far have not proven to be effective in most neurodegenerative conditions. So we're talking, Lou Gehrig's, which is ALS, MS, multiple sclerosis, Alzheimer's, most neurodegenerative conditions. I dare say all of them, but I don't want to say all of them because I don't know all of them because those are different areas of neurology. I am not aware of any neurological condition that responds really well to stem cells. Now, it's a different story for some forms of cancer, especially the blood cancers, lymphomas, leukemias. The stem cells have absolutely proven to be very helpful for those conditions. But the brain is a super complex organ, and stem cell trials, there have been many done for decades. They're not panning out. They're not proving to be effective. However, stem cell trials are still ongoing, and some early trials are showing some promise, though they've been small, 10, 20 patients or so. And others have only been done in rats, not humans. So when people come to me and they're like, oh, I heard about this stem cell work that's really showing some promise, you have to look at that trial. And if you look hard enough, you'll find, well, it was done in 8 patients or 10 patients, or this was done in rats or mice, not in humans. There have been no full-scale clinical trials done in humans that have shown stem cells to be effective for Parkinson's. Same thing with red light therapy. It has not proven to be effective in Parkinson's disease in trials. Most vitamins will not harm you, but there are no vitamins that have definitively been shown to help PD either. Same with diet. We do recommend like a plant-based Mediterranean diet with limited alcohol intake, but that's for good overall brain health. And I'll recommend this to my memory patients as well, and my other, neurological patients. A Mediterranean plant-based diet has shown in scientific studies to be helpful for neuroprotection. So even myself, I try to follow a Mediterranean plant-based diet. It's hard to do in meat-loving Texas, but I do the best I can because I'm such a believer in, that diet being neuroprotective for neurological conditions. This is something I really want to talk about. There is no cure for Parkinson's disease, and there is currently no way to stop progression of the disease. However, there is one definitive way to slow progression, and it is totally free, and that's exercise. Please do not spend thousands of dollars on a program that someone says is going to cure your Parkinson's, because it will not work. There is nothing that will fire me up harder or get me angrier than when I see stuff online saying, I'm a functional doctor, or I'm a chiropractor, and I can cure your Parkinson's, or you sign up and you buy my $5,000 package of vitamins and I can help your Parkinson's, or I can get rid of your Parkinson's. They are lying to you. It is not true. And I hate people who take advantage of my wonderful Parkinson's patients who are desperate for something, and they end up getting bankrupted by these people who are selling them false hope. If you have something you want to try, stem cells, red light therapy, vitamins, whatever, I beg you to talk to your Parkinson's provider first. But before you make a costly investment in something like this, if you want to try red light therapy, stem cell trials, vitamins, whatever on your own, and you have the money to do so, and it's not going to put you in a financial pickle, go ahead. These things, to my knowledge, most of them are not going to harm you, but they're not going to help you. But if you want to try it, okay. But I just do not want you to be investing a lot of your life savings in something like that. Certainly, if you have questions, please ask your provider, and they will weigh in. And then I did put on here, check out clinicaltrials.gov for a list of reputable clinical trials running nationwide. If you want to look for a trial, I would recommend clinicaltrials.gov. But again, exercise, that is totally free, and it is the only definite thing we have. We've got scientific evidence to support this. People who exercise tend to have slower progression of their Parkinson's, and that is free. And these last two I combined in one slide. So I hear a lot of patients saying these things. I'm losing weight. It's from my Parkinson's. Or my knee or my back or whatever hurts. It's from my Parkinson's. I am here to tell you, not everything is from your Parkinson's. Parkinson's can do a lot of things and can cause you a lot of problems or a lot of weird symptoms, but not everything is from your Parkinson's. Can't blame Parkinson's for everything. You can blame it for a lot of things. Can't blame it for everything. Parkinson's patients can have other diseases or conditions that can cause symptoms just like anyone else. So let's talk about weight loss. This is not typical in Parkinson's patients, okay? Parkinson's does not tend to cause weight loss in most people. I have only seen weight loss in people with either severe nonstop tremor, just terrible nonstop tremor all day long, or in people who have those severe levodopa-induced dyskinesias, those severe wiggly movements like Michael J. Fox. I have seen weight loss in those people because their movements are so severe and so constant. It's like they're on a treadmill going all day long. They're burning calories nonstop all day. I've also rarely seen it in people who have such a strong loss of appetite due to the fact they can't smell, which is a common feature of Parkinson's. They can't smell food, therefore it doesn't taste good, therefore they don't have much of an appetite anymore. Those people can lose weight as well. But I'm talking a few pounds with that loss of appetite. If you're having a 30, 50 pound weight loss over a year, you need to go to your primary care and look for another source. It's 99% of the time, it's something else other than Parkinson's. And the last thing is pain. So a lot of patients will ask, my back hurts or my knee hurts. I think it's from my Parkinson's. Well, here's a really important part. of this whole thing. Does it get better after you take a levodopa? Does your pain in your back or your knee or whatever get better after you take a levodopa? If it doesn't get better after you take a levodopa, it's likely not from Parkinson's and it's from something else. Usually it's arthritis or it's spine issues or a bad hip or a bad knee or whatever that are totally unrelated to PD, but are super common in older folks. If it does get better, if your pain or your ache gets better after taking a levodopa, it is likely from Parkinson's, caused by a low dopamine state. Like if your levodopa has worn off, or you just took a dose and you're waiting for it to kick in and you're in a low dopamine state, you can get aches, pain, spasms. I often see this in the form of overnight leg cramps. So that's what you keep in mind when thinking about pain is, does this get better after you take a levodopa? If it doesn't, it's probably not Parkinson's. And that's what I got for you guys today. We love our patients and their families at UT Southwestern Movement Disorders. We have the best patients ever. And I love my patients dearly, and I thank you guys. And so I included a little picture of from my wedding this summer, which is why I changed my last name. It was for a good reason. So thank you guys very much. And I'm going to end my talk here.
Thank you so much, Julia. And thank you for sharing that picture.
Sure. Let me stop sharing. There we go.
Okay, so we have a few questions on here that I wanted to ask you about. So one is that in your fifth point, you mentioned, the gas analogy in the car, and somebody asked, is that a case for someone being less active, which is of course not the case, as you also mentioned. And then, a related question someone asked, so what kind of activities or lifestyles use up dopamine? So if you could talk about that.
Sure, yeah. I definitely understand where you're going there. Like, okay, if I don't move, then I won't burn levodopa. But I mean, simply blinking your eyes is an eye movement. Talking and opening your mouth, swallowing is a muscle movement that is using gas, that is using dopamine to power these muscles, these muscles, these muscles. A human, when they're in awake state, cannot just sit there all day. You're going to burn dopamine just by natural movements. So it's not feasible to just, that's no way to live, just to do this the whole day long. And in fact, it's the opposite. You need to move. I cannot stress enough, the exercise is so crucial to Parkinson's. You just need to may need to make some medication adjustments. So for example, I'll tell patients, some of my patients who exercise pretty vigorously, 30 minutes before they go to the gym, well, you can take an extra half tab of levodopa, put some gas in your tank because you're about to run it down hard with exercising. And I don't want you to go bone dry in the middle of your exercise. So talking to your provider and kind of adjusting your medication regimen can be helpful sometimes for that. What kind of exercise? So cardio is the big one, the one that all the studies suggest to be very, very helpful. So it's not just like strolling around. I mean, it's hoofing it to where you have an elevated heart rate. And that's going to be different for every Parkinson's patient, depending on their balance or their cardiovascular health, things like that. So again, talk to your provider and they can give you some recommendations.
Okay, and then, we have a question about, I guess, what causes Parkinson's, it seems like, somebody wants to learn about how paraquat herbicide, is related to Parkinson's.
Yeah, so pesticides are related. Paraquat's one of the known, things that can cause Parkinson's. We don't know why people get Parkinson's. We don't know why all people get Parkinson's. We just don't. We know there are certain things you can get exposed to in your life that can put you at a higher risk for developing Parkinson's, and the pesticides are the big one, paraquat, rotenone, and things like that. The current thought behind why some people get Parkinson's and some people don't is that you have something in your genetic makeup that makes you more prone to a neurological condition. And then as you go live your life, you get exposed to something along the way, whether that be a pesticide or something else, which we may not know yet right now with our science base, that kind of releases that Parkinson's. So we often use the analogy of your genetics loads the gun, And then an exposure to something throughout your life cycle pulls the trigger and releases Parkinson's, if that makes sense.
So you can also raise your hand and I will come to you, if you have any questions. Meanwhile, there's a question about, can children show symptoms of low dopamine levels, and is there a way to see if that predisposes them to PD later?
Children, like little children.
Yeah.
There are some forms of juvenile Parkinson's disease. Yes, you can get Parkinson's as a child.
Mhm.
Extremely rare. It's very, very rare. Usually a genetic issue going on. I will be honest, I don't know too much about childhood Parkinsonism because those children are treated by pediatric neurologists, and I only focus on adult.
Mhm. I actually met someone with pediatric, PD in Colorado a few weeks ago, actually. So yeah. Um, okay, so somebody's asking about stimulant medications, if they make you feel better and more functional. Are there any reasons to avoid it? Yeah.
Stimulants. I'm guessing that's like Ritalin, Vyvanse, those kind of things. So stimulants are going to make any human more awake, more alert, and things like that. That's the purpose of them. They're a different chemical involved. It's not dopamine, it's a different chemical. I sometimes will give very mild stimulants to some of my Parkinson's patients who have excessive sleepiness. We're not talking fatigue. That was something I was going to put in. I didn't have time to put it in, but fatigue is something a lot of my patients talk about. There's no cure for it, there's no fix for fatigue. However, if someone is excessively sleepy, we're talking like sleep 12 hours a night and then need two-hour naps in the daytime, sleeping excessively, I will sometimes give people mild stimulants, not as heavy hitting as Vyvanse or Ritalin or Adderall, to help keep them awake. But that's a whole other thing. You can't have cardiac problems with any stimulants. So you have to take the whole person's whole health picture into consideration when prescribing those.
Okay, we have Joe raising his hand here, so I'm going to allow him to. You're unmuted, Joe.
Yes, thank you very much. I guess I'm going to expose my ignorance here. Is dyskinesia the term to use as a side effect of the levodopa? Is that correct?
Correct. Yes, those. When you see Michael J. Fox doing this,
That's
that's
dyskinesia.
that's a dyskinesia. The full name is levodopa-induced dyskinesia because it's
And
caused by levodopa.
bradykinesia would be the actual side effect or the actual effect
Yes.
of the Parkinson's. Is that correct?
You got it. You got it. Yeah, bradykinesia is a symptom. It's not a side
Symptom.
effect. It's a
Okay.
symptom. That someone who's not moving much or who moves very slowly, that's bradykinesia. Again, when we do this, I'm
Yep.
going real fast, but Parkinson's patients can often go very slow. That's bradykinesia, slow movements.
Well, let me ask a generic question here, and I know you're not going to be able to diagnose this over the internet here, but my dyskinesia is more uncomfortable to me than my bradykinesia.
Mhm.
So the solution would typically be a reduction in the levodopa, correct?
That's a first step for a lot of people. Yeah, to reduce your levodopa. Yeah.
Okay. All right. Thank you.
Sure, but some people can't tolerate being on lower doses of meds because then they get too slow or they get too shaky. Then there are medicines we can add on to suppress that dyskinesia while allowing you to use higher levels of levodopa. There's a lot of ways to skin that cat.
Well, I just got off my levodopa last night. I mean, I had zero last night and I had zero today, and I'm moving awfully slow, and I don't like that either. So
Yeah, yeah. There's ways to skin that cat. You just talk to your provider.
thank you.
Mhm.
I think there's still some interest in the connection between movements and, the car analogy that you had up there. So, if heavy exercise does not decrease dopamine in your brain, people talk about how they feel better about it, doing exercise. So if you could just like go there again a little bit.
Sure. Yeah, so exercise for most of my patients, exercise does run down their levodopa gas tank. They're moving faster, moving more, just like the faster you drive a car runs down that gas tank more. Some people don't. but a lot of patients do. But regardless, most of my patients feel great afterwards. And exercise is really a long-term benefit. So sometimes you don't feel great after you do it, but if you keep doing it day after day, you'll find in a couple months you feel a lot better, not just for your Parkinson's, but your stamina level, your energy level, fatigue, that can help fatigue, exercise and things like that. So exercise does often run down your dopamine level in your brain. I'm sorry if I wasn't clear about that. But there's, again, ways to skin that cat by maybe giving you a little bit extra before you exercise and things like that.
Is blood pressure fluctuations PD related?
Oftentimes, yep, you can get something called autonomic dysfunction, where that software program that's running in the background of all of our brains that changes our blood pressure and tells us to breathe and changes our body temperature, that software in Parkinson's starts fritzing and frying. Parkinson's loves to eat up that autonomic system and cause chaos there. So you can start having problems with blood pressure dropping when you stand, feeling lightheaded. That's why if you see me in the clinic, I'm always going to ask if you're dizzy, because that can be a problem in Parkinson's, and it can be a side effect of the levodopa, that it can lower your blood pressure and make you feel more lightheaded.
Yeah, I'm going to pass it to Martha, allowing her to talk. Here you go. Unmuted, Martha.
Okay. Is that correct?
Yes, we can hear you.
I have a question that in the morning when I have slept the whole night. In the morning when I wake up, after 1 hour, I take levodopa, and in less than 15 minutes, I get asleep completely.
Mm-hmm.
It shouldn't be, because you said you need to have this solution in your body, and I only get normal after 2 hours. So what am I doing wrong?
I don't think you're doing anything wrong. Levodopa can be sedating for some people. I do have patients that when they take it, 15 minutes later, they'll have to take a nap. So for some people, and not all people, but that is a side effect of levodopa, that they can get excessive sleepiness after they take it. And then 2 hours later, I mean, if you take, depending on what kind you take, the immediate release will all release at once. Your drug level will spike quite high, make you very sleepy. And then again, that graph I showed with the waves up and down, it'll start metabolizing out, and at some point you'll start feeling less sleepy, more awake as your drug level starts lowering, and then you can feel more awake. But I really, without knowing your whole history, I don't know that I can comment on what's going on there.
What should I do?
Talk to your provider.
Okay.
Yeah. Yeah.
Okay, we have Tracy. I'm going to allow you to talk, Tracy. You're unmuted, Tracy.
No, I'm not.
Yeah, I hear you, Tracy.
I have a question about if I graduated from carbidopa levodopa to Rotari and then had DBS surgery. Can you go back to the carbidopa levodopa 100, 125 or whatever it is?
Mm-hmm. Yeah.
And wean yourself off of the Rotari?
So again, if you go back to one of my slides, it's the same drug. Carbidopa levodopa and Rytari, same drug, just packaged differently. I wouldn't call going on Rytari as graduating or getting to you getting worse and you need to go on Rytari, for example. That's not how it works. We use Rytari or carbidopa levodopa for different purposes. Rytari, for example, lasts much longer than regular carbidopa levodopa. So if I have a patient and they're saying my levodopa doesn't last long enough, well, I'm going to switch them, not graduate them, switch them to Rytari because it's going to last longer. Or if a person has bad dyskinesias, sometimes I will switch them to Rytari because that drug level doesn't spike as high, so they don't tend to get those dyskinesias. So they'll tend to have less dyskinesias on Rytari. So there's different purposes and reasons why we choose Rytari versus carbidopa levodopa. So if you don't like Rytari because either it's really expensive or you don't like how you feel on it, you talk to your provider and you say, could I try going back on carbidopa levodopa? And they'll explain why that would be a good thing or a bad thing. But I oftentimes will have a person on Rytari 6 months later, something's not working. Let's put you back on regular carbidopa, levodopa, or vice versa. It's we often change the forms of the medicine depending on what's going on with the patient.
All right, thank you.
You're welcome.
Okay, the last question, because we're out of time. We have someone with young onset Parkinson's who's asking about taking medication before the gym or after, and are protein shakes okay to take?
Yeah, good question. So I usually will have my patients take a little bit extra, about 30 minutes before they go exercise, really top up that gas tank so that if you run down hard, you are not going to run it to bone dry. Sometimes though, if they don't feel good with that, like they try it out, it doesn't feel very good, and I'll say, well, then you can try to take it a little bit extra 30 minutes after. But I think it's good. I think people would generally feel better if they took it before. But sometimes, everybody's body chemistry is so different. So I think you could trial either way. But I would definitely talk to your provider about that because I don't know your whole thing. And levodopa has its own side effects. It could be taking a little bit extra, could give you more side effects as a that. And then protein drinks, they're great, especially for gym. But you want to take it an hour away from your levodopa. Even if you take a little bit extra, you need to spread out the protein away from the levodopa where you won't end up absorbing all that levodopa and it won't have as big of a benefit to you.
Well, thank you so much, Julia. This was absolutely wonderful. I do want to say we will send out a feedback form, and we really want to hear from you how you like the Ask Your Doctor series and all of these sessions. So please do provide your feedback. And I did put a link for our holiday gathering next month. I hope you will all register and attend. We look forward to seeing you there. Thank you so much, Julia.
Yeah, my pleasure.
Happy weekend, everyone. Bye.
Happy weekend.